Welcome, everyone, to More Good Days, the official podcast of Haven Headache and Migraine Center. I'm your co-host, Izac Ross, founder and CEO of Haven. I've lived with chronic migraine since the age of 2. Our podcast is here to help you keep up with the latest research, policy updates, and most importantly, practical advice for managing life with headache and migraine disorders. This podcast is here to provide you with valuable insights and support you on your journey to more good days. In this episode, Netta and I are joined by Dr. Susan Hutchinson to talk about the overlap between depression and migraine. Dr. Hutchinson is a clinical director here at Haven and someone without whom Haven would not be possible. Her unique perspective comes from her background in primary care. Before helping to found Haven, she established the Orange County Headache and Migraine Center and authored the book, A Woman's Guide to Managing Migraine. And just a quick note before we dive in, we strive to make sure that all statements in this podcast are clinically accurate, but it's not intended to be medical advice. Please review with your provider, or if you're in California, make an appointment with one of our headache specialists at havenheadache.com.
We know there's a significant overlap between migraine and mood disorders, particularly depression. Today, we'll dive into this connection, exploring the biological links, the impact on patients, and how we can better diagnose and treat those affected by both conditions. Both depression and migraine are common. Susan, how common are these disorders, and how commonly do we see depression in people with migraine?
This is such an important topic. Migraine and depression often coexist. And when you look at the average person, those that don't have migraine, there's probably about a 10% lifetime prevalence that at some point they will develop depression. When you look at those with migraine, it's greater than 30%. So there's this association that is very powerful. And to be honest, we see it in both episodic and chronic migraine, more so with chronic migraine.
Do we know anything about the chicken or egg problem here? Having a pain disorder is kind of depressing. Your life is really changed. Do we know that what is the causation or correlation between these two?
Well, let me first start by saying there was this amazing study done years ago by an epidemiologist, Dr. Naomi Breslau, and she found what's called a bidirectional relationship between depression and migraine. And when I first heard her give the data, I was just literally stunned. So what were the conclusions? She took populations, number one, those that had migraine, but not depression at baseline. Over a 10-year period, they were 5 times more likely than the general population to develop depression. Wow. Then she also took a population of those that had depression, not migraine at baseline, just depression. They were 3 times more likely to go on and develop migraine than the general population. So you can have both. And if you have one, you're more likely to at some point develop the other. Many different theories, but what's very interesting is when you look at other chronic pain conditions like low back pain, yes, you have depression. But migraine, there's an even greater chance than other pain conditions. So you kind of wonder, what's going on? What's the shared mechanism? I don't think we still know exactly, but there's a lot going on with what we call neurotransmitters. Some of you may have heard of the serotonergic or serotonin pathway. You may have heard of dopamine or dopaminergic. So we think there's some shared pathophysiology of what's going on with these neurotransmitters that may be that shared underlying reason why these two conditions, migraine and depression, very, very often coexist.
So, this makes me think that it's really important to treat these conditions early. Especially if somebody has episodic migraine and maybe we see that they're kind of leaning towards more migraine attacks, they're going into chronic migraine. We really want to control that as much as possible, especially if they may have a higher risk then of developing depression. And a lot of patients do ask, does having migraine attacks make me more likely to develop depression or vice versa? And it sounds like the answer is yes, it is likely.
I agree, Netta, and it's not just pathophysiology and things like serotonin and, norepinephrine and dopamine. There's also environment and circumstances. So when I look at an individual, let's say a patient, and they've been doing pretty well with what I call infrequent episodic migraine, and all of a sudden things are transitioning, they're transforming. you really also need to know what's going on in their life. What are their life circumstances? Let's say it's a divorce or a child with a serious illness or personal illness. So, and those things can predispose to depression. So I think, again, we always want to look at the totality. So I think that's one of the reasons I love the fact that in my background in family medicine, that's what we're taught. We don't just treat the headache. It's the person with the headache. What else is going on? It's also interesting over the years, sometimes I'll tell my patients, sounds like you're developing some depression in addition to your migraine. Some of them, to be honest, Isaac and Netta, they actually get upset and they'll say things, well, Dr. Hutchinson, if you were better treating my headache, I wouldn't be depressed. So sometimes there's that. But the patients that are open to it, I think it's so important because we can't just think, well, if I just get their migraines to better, their depression will get better. Not necessarily. I mean, in many cases, I think depression is also a valid condition, disorder that we also need to treat in addition to the migraine.
I completely agree. It's so important and it can't be overlooked. And do you ever notice that if we're not treating depression in somebody with migraine, that their migraine attacks don't tend to get better?
Well, I see that a lot because, again, over the years, I've had patients very resistant. They don't want me to say that they have depression, even though they really do. And so they only want me to focus on their migraine. And guess what? I see those patients going deeper and deeper often into a refractory chronic migraine condition. They're depressed, they're upset, and it's so frustrating. But on the opposite, if they're open to exploring what can we do for the depression? And it's not just pharmacologic, there's non-pharmacological things as well. So I think if patients who are listening to this, individuals, if you are open to the idea that these two conditions often coexist, and let's treat both. Treating one can help the other, but it doesn't mean you just treat one. I think you really need to treat both. And sometimes you can do it with treatment that will help both conditions.
Does depression, in your experience, influence the severity or frequency of migraine attacks?
Yes, I would say yes. In other words, if I have patients that let's say I initially diagnose them, if they have depression and migraine, boy, I need to watch that person extra carefully compared to someone who maybe they have episodic migraine. They're not depressed at all. They're living a great life. So if they have depression, I'm going to watch that person a little more carefully because for among other things, sometimes they're not even happy in between migraine attacks because they just, they're depressed then too. And also to point out, depression isn't like, man, you want to commit suicide. Sure, that's the more severe depression, but sometimes depression can be just going through life and you're really not interested in things that used to make you happy, things like gardening, whatever that may be, spending time with family. So sometimes there can be different degrees of depression. So I think it's so important for those of us treating headache patients to look for those subtle signs of depression, not just the major things like I need help, I want to commit suicide. There's so many other different degrees of depression.
For you in practicing headache medicine, what are those red flags that you're looking for in your appointment or in your conversation with a patient that might indicate
There are
that
so many things, Isaac, I look for, but I always ask patients about their life. Are they exercising, eating healthy, how's their sleep? And I often find that when patients are depressed or getting depressed, they often, well, I don't really feel like going to the gym, or no, I haven't been as good about, what I'm supposed to be eating. I know you've talked to me about it. There's often just this dissatisfaction with their life. They're complaining about things. They don't feel fully engaged in life. Maybe things that used to make them happy don't make them happy. So those are some of the signs I look for. But, with Haven, one of the things I think that we do really well is we try to screen for that. So for all new patients, we do that thing called the PHQ. And all of our listeners, you can look at it, but it's just two simple questions. So the first question would be, over the last 2 weeks, have you felt depressed, down in the dumps, not feeling good? And then the second question would be, over the last 2 weeks, have you lost interest in doing things that normally make you happy? That's something called apathy. And sometimes that can be a very early warning sign. And to put this in perspective, all of us, including me, both of you, we have a bad day. I mean, once in a while I have a day that I to be honest, I feel depressed. But guess what? I'm usually better the next day. So I usually bounce back pretty quickly. Often it's situational or circumstantial. So when you're looking at the PHQ-2, it's not just, yes or no to those questions. What it's scored is that over the last 2 weeks, is it all the time that you feel that way? Is it rarely? So again, it's a little bit of a scoring system. And then if it's positive, there's a further screen that you can do called the PHQ-9. And all of this is readily available on the internet for listeners. So again, all of us can have a bad day. All of us can feel depressed here and there. But if you have those depressive symptoms day after day after day for at least 2 weeks in a row, that I think is cause for concern where I think intervention is necessary.
Yeah.
I think that that's something that's like a very big strength of how we've set up Haven, in that we take this very integrative approach where oftentimes when you go to a neurologist, they're really looking at one slice of your life, which is just that headache. When you come in and go through the process of becoming a patient at Haven, we are looking at not just your headache, but your mental health, your lifestyle, and looking at that more global approach. Maybe this question is both for Netta and Susan. What difference have you seen in, the tools that we give you, but also comparing that to kind of the standard approach and how that helps you improve the outcomes on the headache side?
Well, I think it's great because, sometimes in the past when I was in my own practice, you get busy talking to a patient about their headache and you start asking so many questions about their headache, you sometimes forget to step back. And quite frankly, sometimes I would forget to screen for depression and anxiety because I was caught up in the details of the headache. So what's nice with Haven is we get that baseline, those baseline assessments done before the first visit. And also we screen for anxiety, and that's called the GA2Q. Why is that important? Many times depression doesn't exist by itself. Often patients that have depression also have anxiety and vice versa. So what's nice about Haven, those assessments are part of what's done before we even have that first visit. And we review those before the visit. So I think we already have that information, and that can help us to have that really spend our time very importantly and very valuable in looking at that, particularly if the assessments show that, yes, the person looks like they do have depression or anxiety. That's really good for us to know even before the visit begins.
Yeah, it's been so important. And one other thing that I like to do with all my patients is, take a step back and just ask, what is your day-to-day life like now? I recently had someone tell me, well, I basically go to work, I can barely get through work, I go home and I don't even want to leave the house anymore. And in hearing that, it was very clear that depression was playing such a big role in headaches. And it's so helpful to have these assessments because it makes us realize how important asking these other questions can be.
I
Absolutely. And well, something to think about, and I used to do this in my family medicine office, is let's say you do diagnose someone with clinical depression and you can get a score on, in that case, you would do the PHQ-9 because you've identified them as having depression. What can be really rewarding is maybe 6 months, 9 months later, you can redo that PHQ-9 and then you can show the person it's working. Let's say it's a medication, exercise, their life. So I think that's something that is good to consider too, is it doesn't mean you're always going to have that same score. And it doesn't mean you're stuck with depression. With the right intervention, wow, things can get better.
just to share my personal experience, not with depression, but with anxiety, that was a huge issue for me alongside my migraines, and tackling that anxiety component. And as we transition into treatment, tackling that anxiety component with a medication that can tackle both really made a huge improvement in my quality of life and in my migraines.
I'm so glad to hear that. Again, you mentioned anxiety. That also is comorbid with migraines. So both conditions, and we really need to identify that ideally. And again, not just treat the migraine or the headache.
And so, how would you approach treatment when a patient has both migraine and depression?
Yeah, that's a great question, Netta, because I think each of us as healthcare providers, we have to know our comfort level in diagnosing and treating. Now, with Haven, we always try to identify who the primary care provider is, which could be family medicine, internal medicine. For an elderly person, it could be a geriatric specialist. I like to collaborate. We always like to with the primary care. So in some cases, The primary care might have already started treatment with an antidepressant or an anti-anxiety. Maybe I want to tweak it, or maybe I think a better one may be a little bit better if we're going to also try to prevent the migraine. But I don't want to take the place of that very important primary care provider. Now, certainly in some cases, the person may be seeing a psychiatrist or a psychologist. So again, working together with those other professionals is so important. Now, I think each one of us with Haven, I think most of us are comfortable sometimes using an antidepressant, particularly if it might help the migraine as well. But we don't go beyond our boundaries if we think the person also needs someone else to help the depression.
And do you ever notice that, if someone has both migraine and depression, that they respond differently to treatments if they just have one condition on its own?
Yeah, I would say in general, if a person just has one condition, it's probably going to be a little easier to treat. Let's say at Haven, we have a person who has migraine, absolutely no depression. Boy, I can be very specific with an anti-CGRP medication, one of the newer ones that have come out. Boom, I'm happy and things are done. But no, if the person has depression, I sometimes can't just use a migraine specific treatment. I really need to think, do I need an antidepressant? Or what about biofeedback? Or what about referring to a psychologist? I remember years ago, I was giving a presentation in the hospital auditorium to a big group of, patients with migraine. And one of the women stood up during the question and answer, and she said, I just want everyone here to know that I was really struggling with migraine and depression. And finally, when I saw a psychologist, and I went through some things that happened in my childhood and talked it through, man, I'm so much better. So the other thing is, for those of you listening, if there's any history of childhood abuse, domestic abuse, bad things, that's not going to just be cured with a migraine medication or antidepressant. Sometimes we need to work through those things in therapy. And it's a true fact, because I was part of a study years ago, and we looked at chronic migraine. And we identified these were practices all over the country, and I was one of many investigative sites. And in our patients with chronic migraine, we asked if they would do a confidential survey. Even I didn't have the results. It was all fed into a big computer and analyzed. It was unbelievable, the percentage of childhood abuse and childhood maltreatment in patients with chronic migraine. And so I think it's really important. And sometimes patients aren't even aware of it until they go on for therapy. So if you're listening and you have a really refractory chronic migraine condition and you feel like just regular antidepressants don't help, maybe therapy to really look at what's going on in your past and even in your current life could be really a valuable use of your time.
I think
Just to
that's
sort
such an
of,
important point, that it's really a multi-dimensional approach to treatment, and it's not just about medications, or it's not just about therapy. It's both.
Yeah,
just
because
to
we
sort
need
of,
to know, people need to look at what's going on in your life. How's your marriage? How's your job? What's the relationship with your kids and your friends? All of that's important.
just to sort of double click on that traumatic connection, maybe can you talk a little bit, Ned or Susan, about the epigenetic linkage of migraine to childhood adverse events?
Yeah, when I think of epigenetics, again, we think that many of us are genetically predisposed to things like migraine, or perhaps predisposed to depression. But then there's this in the environment, right? So we're born with a genetic predisposition, but our environment, things like childhood adverse events. And it's not just being physically abused, it could be neglected as a child, or maybe a teenager gets bullied at school. There's these genetic predispositions, but then the environment, that comes, that can really, I think, increase that chance of a person really becoming refractory and not doing well. Years ago, when I was trying to understand epigenetics, I remember this cartoon, and it showed a woman with migraine. And in the past, her life was pretty simple when she was a cave woman or whatever. But fast forward, she's in a kitchen and she's multitasking and tons of things are going on. And then it was like, okay, I think the slide or the cartoon was meant to represent yes, there could have been that genetic predisposition, but look at her lifestyle, crazy, stress compared to years ago. So kind of that understanding of, we have genetic predisposition, but then the environment, the family, the circumstances, all of that can also shape and affect our physiology and our predisposition to conditions.
Are there any specific antidepressants that are preferred for patients with migraine?
Yes, when we look at antidepressants, which have been used for years to help migraine, even though I may comment they are off label, none are officially FDA approved. For years, we've used the tricyclic antidepressants. It is not a bad choice. And you know why? Because they work on both serotonin and norepinephrine. I think the antidepressants less likely to help would be those that only work on serotonin, things like Prozac, Zoloft, or ones that only work on dopamine and norepinephrine like Wellbutrin. Some of my favorites are Cymbalta, which is duloxetine. That works on both serotonin and norepinephrine. There's another one called Effexor, venlafaxine. That also works on serotonin and norepinephrine. They're both good, and in fact, Effexor, venlafaxine, has been widely recommended as a migraine preventive. But the problem I have with it is if a patient forgets to take it, even for a day or two, they can have horrible withdrawal symptoms. So with patients I see at Haven, I would be more likely to probably go with the Cymbalta. Fortunately, it's now generic as duloxetine. What's interesting about it, it's also FDA approved for fibromyalgia. So even with fibro, we think there's a shared pathophysiology with fibromyalgia, depression, and migraine.
No, that's super helpful. Do you find any risks when taking both an antidepressant and, migraine-specific medications?
That is a great topic to briefly consider. Many of my patients over the years, as yours, Ned, have probably gotten these warning signs about serotonin syndrome.
Yeah.
And it's in the pharmacy database, and that would be if you're on an antidepressant that increases serotonin, whether it be Cymbalta, Effexor, Prozac, Lexapro, and we prescribe a triptan, things like Imitrex. It's extremely rare, and I have never seen it, Netta or Isaac, if a person is on just one antidepressant and they get triptan as needed. I think the risk is when a patient is on multiple medications that increase serotonin, a tricyclic and an antidepressant and some kind of a pain medication like tramadol, and they're on a triptan. So I think we look at the totality, but I believe the last I checked, there's only about maybe at the most 20 cases of true serotonin syndrome. And there was a database a number of years ago that took 45,000 patients that were on both a serotonin type antidepressant and a triptan, 45,000 patients and not one case of serotonin syndrome. So the risk is there, but it's extremely rare.
Yeah, I think in general these are safe and they're safe to take together, and I hope our listeners and our patients aren't afraid to try them.
Yeah, I think most providers are now aware of the fact that the risk is so low. But I'm hoping now when providers across the country get those warnings from the pharmacy database, they understand it's still their clinical judgment. And particularly if you look at most patients are not supposed to take the triptan every day. So the triptan is as needed.
Who should be managing these antidepressants? Should it be the headache specialist, or should patients be followed by a psychiatrist?
What a great question. Well, first of all, I know this happened to me in all the years I was in family medicine. There's often not enough psychiatrists, and many psychiatrists don't take insurance. They want the patient to pay out of pocket in full. So that was a challenge for me. Fortunately for me, I had a very strong interest in depression. So I would say at Haven, or if a patient's seeing a neurologist, I think it's fine for us to prescribe an antidepressant if we're comfortable with that particular antidepressant. A good example would be Cymbalta, and especially if we're doing it because we're not just helping the depression, we're going to see if it helps the migraine. I actually think the person we need to work in conjunction with the most closely is actually the primary care provider. Most primary care providers are comfortable managing depression, so I think that's the person I would want to collaborate with. And then many times my patients, they may benefit from seeing a therapist or a psychologist, but those particular specialties they don't prescribe. Now, in some cases, I know that there is a new field where you could have a nurse practitioner. They call them psychiatric nurse practitioners, psychiatric PAs. So in some cases, the person may be able to be referred by a nurse practitioner who can handle the meds. Now, having said all this, when should we not be the one treating the depression? If the person is suicidal, that should not be managed by a neurologist, primary care, or us at Haven. And also, kind of on a humorous note, when I was in my family practice days, I was also comfortable treating bipolar disorder. But what I would tell my patients is if you are hearing things that I don't hear, you are seeing things that I don't see, that's too much. You need to see a psychiatrist. And what that's referring to is auditory and visual hallucinations. So I think I speak for Netta, myself, and probably for most providers that if we're not comfortable, yeah, then it's time to refer. But I think most patients with depression, in my opinion, can be handled either by us at Haven if it's comorbid with migraine or in conjunction with their primary care provider.
And what role do you see cognitive behavioral therapy or other psychological interventions playing in these patients?
Well, I think cognitive behavioral therapy can really help. And for listeners that aren't quite familiar with that, when I think of cognitive behavioral therapy, it's a way to get people out of their negative thinking. Let's say a patient's like, oh, woe is me, I'm never going to get better. How can we turn that into positive? And oftentimes, cognitive behavioral therapy is combined with things like biofeedback, stress reduction. And that whole area of non pharmacological really has good evidence, to be honest. And I would highly recommend it for all those that are wondering about it. Because I think if you do that and an antidepressant, the combination of the two often work better than either by itself.
Yeah, that makes sense.
Have neuromodulation or any of the lifestyle treatments shown any promise for both conditions?
As far as neuromodulation with the non-invasive neurostimulators, I believe there's some early research showing that there may be some benefit with depression, but they're not yet what we call FDA cleared or approved for that indication. But gosh, if using a non-invasive neuromodulator could help someone's mood as well as help their headache, I'm all for it. And I think they're extremely safe. I think lifestyle, though, wow, if I could do one thing lifestyle for my patients, it would be for them to exercise. Now, admittedly, I speak as someone who loves to exercise, but exercise can be such a positive way to get in a better mood, to increase the oxygenation, change your attitude about things. Certainly other lifestyles good too, like eating healthy. Getting enough sleep is so important. I know if I don't sleep well for a couple nights in a row, I kind of get a little irritable and I could probably get a little depressed. So I think sleep, exercise, eating healthy, limiting alcohol. Remember, alcohol can be a depressant. Some people turn to alcohol thinking, well, it'll help me sleep. But then what happens? You wake up in the middle of the night, you can't get back to sleep. So be careful with alcohol. Either don't drink or drink in moderation. Caffeine, too much caffeine can make you jittery and anxious. So lifestyle, I think, is really, really important.
And what about any new treatments or promising research on this topic? Have you heard of anything coming up?
Yeah, what a great question. I believe we're going to see more and more with ketamine. I am not an expert with ketamine, but my daughter's a licensed therapist, and there's something called ketamine assisted therapy, where some patients are able to talk about things that have happened in their past. I believe ketamine is sometimes used now for refractory depression.
Mm-hmm.
There's also, I think it's called TMS, but it's the transcranial magnetic stimulation. I think there's some research using that for refractory depression. So I think we're going to see ketamine. We're going to see more research with the non-invasive neurostimulators. So yes, stay tuned. I think there's a lot we're going to see in the future.
I love seeing all these new options for both migraine and other conditions like depression.
Yeah, I do also.
If patients aren't able to access Haven, if they're outside of California or may not have the right insurance for us, how can patients advocate for themselves when talking to doctors about both conditions?
I think if patients aren't able to see us at Haven because they're not in California, again, I was a primary care provider for 22 years. I really recommend please start with your primary care provider. Primary care providers are trained to recognize and be able to treat. But if you're just going in for your physical or sore throat or sprained ankle, you may not realize that you may have a very good advocate. And then you could maybe do the PHQ-2 or the PHQ-9, do a little bit research yourself, and then make an appointment with your primary care just to talk about your mood or your depression or your headache with the depression. Because ideally, your primary care provider, they're there for you. And they're like the quarterback of your team. And if they feel that you need to see a headache specialist, like a neurologist in your area, if they think you need to see a psychiatrist, psychologist, they're the ones that can facilitate that referral for you. So again, I guess I'm trying to elevate the importance of starting with your primary care provider.
That's great advice. And is there anything else you'd like to add about the connection between depression and migraine that we haven't covered yet?
I don't think so. Just to emphasize that it's very real. And if you're struggling with depression, you have migraine, don't just think that helping the migraine is going to help the depression. The depression also needs to be evaluated and treated.
Thank you so much, Susan.
Yeah, thank you for
It's always
joining
a
us.
pleasure. Always a pleasure to be on a podcast with both of you.